A quick but heartfelt expression of gratitude to Larry Gold for his vision and energy. A thank you to Carissa Gold and Roger Waltz for their industry and competence, and to the technical staff as well. Pardon me, psychiatry. Is it different? If so, how? Please allow the how to have two meanings, qualitative and quantitative. In what manner is psychiatry different? To what degree is it different? In ancient times, mental illness was little recognized, certainly less treatable or treated. Few instances of madness were recorded amongst kings or other individuals. Various interpretations of what madness might be, different manifestations, and the popular conception involved seizure or possession by a supernatural power. Fast forward to the Middle Ages. Hieronymus Bosch gives us the extraction of the stone of madness. Can you see that? You'll notice that the surgeon here is accompanied by a nurse and a priest who's moonlighting as an anesthesiologist, I suspect. I don't get what's with the hat. 75 years later, another image of the same procedure out of Holland. Once again, we've got a nurse. There is an anesthesiologist in there. His job is to hold the poor afflicted man steady, and the surgeon at least has the advantage of good Dutch magnifying lenses. In the Middle Ages, demonic possession offered the most satisfying explanation. Curing demonic possession naturally involved driving out demons. We have ancient and more recent examples from Sumeria in the New Testament, and the documented story of the devils of Loudun. That was a story of mass hysteria in a convent, which resulted in pretty serious torture and executions. As recently as 1789, King George III's doctors treated his madness, apparently the result of acute intermittent porphyria, by restraining him and applying caustic poultices to draw out the evil humors. I wish I had a better resolved image of this painting, dear to the hearts of Western psychiatrists. It was painted in 1876, but shows an event from the 1790s. In Paris, Dr. Philippe Pinel orders the removal of the chains from the patients at the Paris Asylum for Insane Women. Dr. Pinel was quite a humane practitioner. He practiced at the Salpêtrière in Paris, and he genuinely related to his patients. How do I make this go down? I'm not sure. I don't need to. He also identified precursors of severe mental illness. He identified grief and loss. He identified the results of the experience of violence from the French Revolution, and he noted fanatical devotion to religious or political causes as, in fact, factors in the development of insanity, as it was then called. For 30 years, he was the chief physician at the Salpêtrière. The 19th century probably represented a regression in terms of scientific understanding. Once again, we had lunatic asylums where people were not treated quite as well as Pinel had chosen to treat them. Insanity came to be regarded as a physical disease, with an attitude that placed great stress on heredity and physical appearance. Even though exorcism of demons no longer made sense, the new attitude added very little in our attempts to treat mental illness. Freud, the link here is that Freud studied at the Salpêtrière 80 or 90 years after Pinel had freed the insane from their chains. Freud was a gifted neuroanatomist and neurophysiologist. He never abandoned his wish to correlate motivation and intention with neuroanatomy, but of course his voluminous work concentrated on the peculiarities and problems of what actually motivates human beings. Entering the world of contemporary neuroscience, I've chosen to feature Dr. Seymour Ketty, who used the marvelous Danish databases to do his twin studies, which yielded the discovery of the genetic basis of schizophrenia. I heard him joke once about the quest for the schizococcus. Needless to say, he was far too sophisticated to believe that a single causation, let alone an exogenous one, would explain such a complicated disease. At the time that, by the early 60s, when he had established the theoretical and research bases of what I would call modern psychiatry, we'd already landed upon some effective pharmacologic treatments. And that coincided with Ketty's research. I'm going to talk about these 5 topics: serious mental illness and treatment, psychiatric diagnosis and research. That's about as scientific as I'm going to get. Money, mental health parity, and trends in psychiatric treatment. The current status of mental health in the United States, the past 5 decades, have indeed brought about a tremendous expansion in the recognition of psychiatric illness in the U.S. and in the utilization of services such as they have existed. The prevalence of serious mental illness exceeds 5%. I'm going to define serious mental illness as a diagnosable condition which results in impaired functioning in the social or occupational realms of living. There are other definitions. Approximately 1 in 4 adults at some point in his or her life suffers from a mental health problem. I don't know if this is shocking or not, probably not. Altogether, only 60% of those affected by serious mental illness actually receive treatment. A recent study shows that only half of the adolescents severely impaired by mental illness ever receive treatment for those disorders, their disorders. An example of mood disorders in the U.S., 12-month prevalence of 9.5%. That includes those that would be classified as serious mental illness, but also those perhaps less severe. Nevertheless, only 51% of all those with mood disorders receive any treatment at all, and less than 20% receive minimally adequate treatment. Approximately half of those classified might be considered severe. Those certainly not necessarily the ones that are receiving the treatment, let alone adequate treatment. This is an image of the DSM-IV, Diagnostic and Statistical Manual of the American Psychiatric Association. We've been on the more brightly colored 4R for a number of years now. That stands for revised. DSM-5 is due out in 2013. And I'm going to take the position, the purpose of the DSM, which goes back, 60 years, was to provide a platform of consistency and reliability in psychiatric diagnosis. Has it succeeded? I would say yes, for the most part. The problem with this volume is that clinical research, or a major problem with the volume is that clinical research is limited by the terrible imprecision of standard diagnostic categories. And in fact, the strategies used to create and develop the DSM are full of potential biases. For one thing, they're subject to social and political controversy and influence. I doubt that the cardiologists would put up with that stuff, but I don't know. In the real world, the application of these categories tends to be overly inclusive. There's an enormous economic incentive to make that diagnosis, to make it consistent with the DSM categorization, and that leads to lots of over-inclusion. That's certainly my opinion. Let me quote from yesterday morning's lecture. Kevin said drug discovery is bloody hard, and yes, it is. And drug discovery is hindered both by the imprecision that I spoke about, as well as by the over-application of the diagnostic categories. Personalized medicine for depression. Can we match patients with treatments? I'd begun to compose this slide, and then, sure enough, in December, there's a paper with exactly that title. The answer is thus far no. We've been unable to overcome the wide variability amongst patients in a given diagnostic category. There were hopes that endocrine findings, EEG findings, might predict preferences or differential desirability of one treatment over another. It turns out that's not the case. They're not terrible in predicting overall prognoses, but they're not very good. Those indicators are not very good at pointing the way to specific treatments. Despite common clinical lore, common clinical usage, such observables as insomnia or high anxiety levels are not demonstrably helpful in choosing specific medications for psychiatric conditions. I call this the Vexing Triad. General predictors of prognosis are often conflated with predictors of response to specific treatments. Specific treatments look good, but don't really stand up to differential scrutiny. Specific responses in given patients may vary tremendously across successive episodes of illness. Most of the illnesses studied, I think for reasons that Larry alluded to yesterday morning, tend to be chronic or recurrent illnesses, and any individual episode of illness in a given patient is influenced by its severity, its depth, its duration, and characteristics of the individual patients. We need larger research samples, more so now that over the last 15 years, studies show that the placebo effect is actually growing. Ouch. Person-level predictors in multiple episodes, we'd like to have those, and we'd like to be able to attend to combinations of several weak predictors. Transport genes for neurotransmitters hold out hope for differentiating within large patient groups. I hope that proves valuable and fruitful. Thus far, I would say not so, and there are significant difficulties with regard to research design. I'm going to talk for a moment about costs. I'll introduce that with a final image from our archives of great moments in medicine. This is a procedure called presenting the bill. You're supposed to laugh at that. This is from Mad Magazine, circa 1960. The doctor here doesn't need any help in performing this particular procedure. No nurses, no anesthesiologists. We would probably now regard this as allegorical. This is the healthcare industry generally, and here's the afflicted taxpayer, you and me. Here's a graph. This is general medical expenditures. I've not gotten to mental health expenditures. Yes, you'd like to think that that's a graph of expenditures. It's not. It's a graph of percent of GDP given to health care, 57% from 17% at the moment. 16% in 2007. I think we're up to 17, and it's predicted we'll be at 19% GDP pretty damn soon. 57% from private sources, 43% from public programs. Don't worry too much about the pie chart. This is a pie chart of governmental spending on healthcare overall. I would call your attention, okay, so this is Medicare, Medicaid, children's health insurance program, federal employees' health benefits, the Veterans Administration. But let's look at this. That $36 billion is in the Pentagon budget. That's embedded in defense spending, but it is the military's costs of treating soldiers and retirees. I am going to ask you to take my word for it. That number is really on the rise, as you might well imagine. Mental health expenditures total approximately 7% of the total expenditures. That's a lot, and that 7% reflects 2003 numbers. The mental health expenditures are likely to double by 2014. Governmental expenditures, both federal and state, for mental health care. The one of most immediate concern, they're all of concern, of course, but the most immediate concern is the state and local 40%, because my state, California, is broke. I don't know how we're going to handle that. Switching to the concept of parity. Parity has been a rallying cry and a battle cry of mental health advocates for 30 years or more. It generally refers to economic factors, insurance underwriting and reimbursement. Obviously, it refers to social and cultural factors as well, but we're going to be talking about the economics of parity. 1968, the Alcohol and Narcotic Rehabilitation Act. This was important. It reflected the ascendancy of the medical model, standard medical model, overriding the still persistent moral weakness model of alcoholism and substance abuse at that time. In 1996, many years later, almost 30 years later, Congress passed a Mental Health Parity Act. I'm going to get to what that is about in the next slide. Let's just defer that for a moment. Importantly, in 1999, President Clinton directed the Office of Personnel Management to institute parity, equality in the federal employee program. He could do this as an executive directive. For 10 to 15 years prior to Clinton's directive, the actual use of mental health benefits within the federal employees program, which is a large one, had declined. The actual numbers had declined. It was thought that that was because mental health benefits were discriminatory, and so he issued the directive. Finally, we get to the current law of parity, 2008 Mental Health Parity and Addiction Equity Act, applying to all group health plans and Medicare Part B. And this is what parity is actually about. It's about deductibles, co-pays, limitations on annual payouts, lifetime payouts, number of visits or hospital days, and the law says that these factors can be no more restrictive for mental health diagnoses than they are for medical surgical diagnoses. Finally, standards for determining medical necessity and reasons for any denial of care must be disclosed. That's where we are now. Why did Congress get around to this finally? I've listed 5 reasons. One, I think, science for biologically defined causes of mental illness and the development of useful pharmacology. Congress believed that this would allow for the effective management of mental health benefits. Studies demonstrated an increased productivity from psychiatric treatment, very important. Overall, a decreased stigma attached to the recognition, the diagnosis, and treatment of mental illness throughout society, pretty much. And finally, one that I wish I didn't have to add, which is the obvious need for treatment of war-induced psychological disorders. Needless to say, another reason why Congress saw parity as feasible was because of lobbying efforts. Psychopharmacology's dominant role in mental health treatment. Let me, before we get to the slide, I need to offer some very simple definitions. Psychotherapy, that means that licensed professionals listen and talk to patients in an attempt to provide encouragement as well as education toward beneficial change in the patient. I'm going to use the term medication management to mean what all doctors do when they prescribe medications, which is ongoing assessment, monitoring, checking to see, and modification of treatments that have been prescribed. Something I'm going to be talking about a bit, medication only or meds only. I don't know if that appears in official publications. It's certainly widespread in my field. Medication only refers to a 10 to 15 minute procedure in which a patient sees a psychiatrist. The psychiatrist runs through a checklist of symptoms, dissuades the patient from expressing personal concerns or what's going on in the patient's life, and the psychiatrist's only task is to say, okay, you're good to go with the medication you're on, or increase the dose, often done, add another medication, and so we get what I would call promiscuous polypharmacy. Onto the slide. For the past 30 years, the use of mental health services has finally continued to expand. In the 10-year period, 1998 to 2007, the use of psychotherapy, talk therapy, held steady at 3.3% of the population. Nevertheless, medication only, meds only, rose from 44 to 50% of the total expenditures. Now, why was this? I'm going to give you a few reasons. SSRIs, that's selective serotonin reuptake inhibitors, are very easy for all physicians to prescribe. They're good. They do a good job. But most importantly, they're safe. And so lots of docs feel comfortable prescribing them. Second reason, Is direct advertising stimulated the public to ask their doctors? I know Ruth Crowe spoke about this yesterday. I'm reminded of the classic film Bedazzled from the late 60s. That is the first version of it. Beelzebub has a chip on his shoulder and is pretty disgruntled about having been rejected from heaven by God for his insubordination. And he retaliates, and I quote him, I brought in advertising. Meds Only allows much easier control of expenditures, especially as an alternative to psychotherapy. I would like to say that control is the major issue here. In specialty and managed care settings, drugs often were not covered, and non-medicated psychotherapy, that is psychotherapy alone, decreased from 16 to 10% of all mental health treatment between 1998 and 2007. Medication only, and now I'm getting into the realm of insurance coverage. Medication implies the use of a near identity of psychopharmacology with other forms of medical and surgical care, whatever the limitations of meds only. Psychotherapy is increasingly regarded as very difficult to control, and this creates a natural incentives for payers to downplay psychotherapy in favor of medication, and to create parallel incentives for practitioners. Despite the law of parity, which I've gone over, insurance companies do find a way to limit mental health payments. Insurers object to the possibility of being responsible for treating fad diagnoses such as caffeine addiction or jet lag. They do not want to be responsible. We can understand that, for negative feelings. And perhaps most of all, insurance companies do not like the open-ended nature that frequently attaches to psychotherapy. The way to limit payments, especially for therapy, is to require pre-authorization for any block of therapy visits. This is burdensome and clearly uncertain for both the patient and the psychiatrist. It decreases, or the therapist in general. I shouldn't limit that to psychiatrists. We'll talk about that in a moment. This decreases the effectiveness of treatment, and it inhibits doctors from even initiating psychotherapy. Okay, I'm going to wind it up. How is psychiatry the same? And that is the same as other branches of medicine. Scientifically, the field seeks to inform its practice with the most current findings of genetics and neuroscience. Socially and culturally, it adheres to a value-neutral medical model. Epidemiologically, psychiatry certainly hopes to develop preventive strategies, yay, yay, I'm for that, and programs as well as the quest for magic bullets. Economically, informed choices will have to be made, but also psychiatry is the same, that practitioners do get pushed around by economic forces, including those of governing reimbursement schedules. How then is psychiatry different? Historically, the vastly complex territory meant that we got to the table, to the scientific table, relatively more recently, and perhaps even now we're more open, I'm not saying that this is bad, open to the findings of social science as well as to those of biology. Politically and economically, psychiatry may have attained legal equality, but parity in practice, I would say, is not quite at hand. Now, here's a real difference, and that is that within the field as it's understood by both the government and insurers, many practitioners do not have MDs. These are psychologists and social workers and marriage and family therapists. A citizen can walk into the office of one of these and request therapy and get it without a referral from an MD. In California, at any rate, that's different from, say, your friendly physical therapist. I know for many of us, the physical therapist has become our BFF in recent years. But in California, the physical therapist needs a referral from the neurologist or the orthopedist in order to ply his or her trade. And he's happy to do that. But in psychiatry, we have many people who are not MDs who do not require a referral. Again, I'm not saying that's bad, but it does make for a complicated system of perceptions and misperceptions and territoriality and hierarchy and differential reimbursement schedules and differential status. And I thank you for listening. Thank you.
How about a few questions? You want to? Yeah.
Thanks, Doc. It was a great presentation. I did a little bit of volunteer work with the mental health ombudsman and testifying before the Joint Budget Committee here in Colorado. And it always kind of seemed that, there was funding that was kind of pulled together to help a lot of different mental health aspects, because, there's a lot of different people that have different mental health issues, and genotypes and so on and so forth can affect some of those conditions. But my question is kind of geared towards what seemed to be my biggest problem was with the label, the dalliance with improved health care, diagnosis was a big issue. Trying to get, because if you get someone properly, and that's kind of getting back to the DMS-4 that we're noting, that there seems to be a lot of leadway in what's actually provided to the public at large as far as health care when it comes to mental health. So it just kind of came down to getting the proper diagnosis, thereby the proper treatment. And I know what the standards is that you're supposed to give someone a diagnosis, and then if you're going to give them a medication, you give it based on that diagnosis. But when I was speaking to some people in the psychiatry profession, they were saying, well, it's not so important to diagnose someone. It's just basically what are their symptoms, and you give them a drug for their symptoms. So I just want to know what your feedback might be. Any comment you may have on that. So thank you much.
Well, for better or worse, you can't get reimbursed without giving a diagnosis. So what often happens is the doctor doesn't pay attention to diagnostic specificity and instead just makes one up. I've encountered that at various conferences. I think that's unfortunate also.
Can I ask you just to back up a little bit and say your deepest truth about the problem of the placebo effect, the metrics for whether or not drugs or therapy, talk therapy, actually work in your mind?
Drugs work and talk therapy works, but talk therapy has to be applied in a far more rigorous and precise way than it was throughout the latter half of the 20th century. I would say, Larry, that the key to the use of talk therapy is to convert passive to active. And we've heard that throughout this conference, throughout this symposium. Many people have said it, that healing occurs when people take charge of their own fate, and that's certainly a touchstone of the therapy, including, by the way, psychoanalysis, believe it or not, which is thought to be a terribly passive experience. I don't believe it is, and that's how I do things, best I can do.
Yeah, just a quick question. The issue of mental health, I mean, a hugely political issue around the world, and things have changed one way or another. what country nationally would you say has been really going down the right road in terms of dealing with mental health and dealing with it from a systemic standpoint?
That's a great question. In preparing this, I made contact with two experts who are the Danish and the German au pairs that we used when our kids were little. They're now 30. I think the Scandinavian countries have done the best job. I looked over all their literature, websites and so forth, and that's my answer to the question. I wanted to say one more thing. I had told Ruth Crowe this earlier this morning, and that is I think that what psychiatry has to offer is to embed itself in primary care settings where we can lend our expertise to the people who are seeing patients. And I think that that's probably psychiatry's best bet in the coming years.
Just as a follow-on from what you said, I mean, is one of the issues, because in Scandinavia, I mean, it's significant that you said that, there is a more communal and shared notion of this than there would be here, where it's your fault. It's the individual who's at fault. Is that a fair?
Yes, absolutely. Certainly.